Hey guys, I hope everybody's fine in this pandemic. So today, before I start with the topic, let's see a case study. A 31-year-old man with chief complaints of progressive weight loss, exophthalmos, fatigue, excessive sweating, tremors, diarrhea, and heat intolerance. So, who the culprit can be? Yeah, it is the hyperactivity of the thyroid gland, which is called hyperthyroidism. So, today I will be talking about the surgical anatomy of the thyroid gland. I am HRITIK Rasikkumar Savla and let's start the topic. First is the location. The thyroid gland lies against the C5, C6, C7 and T1 vertebrae and it encircles the trachea posteriorly. The isthmus extends from the second to the fourth tracheal rings. What are the main functions of the thyroid gland? It secretes T3, T4 and calcitonin. It regulates BMR and stimulates somatic and psychic growth. What are the important relations of the thyroid gland? The important relations of the thyroid gland include the skin, superficial fascia with the platysma and the anterior neck muscles anteriorly. Posteriorly, it is related to the trachea and esophagus because it encircles the trachea. Laterally, it is related to the carotid sheath with its contents, which are the common carotid artery, internal jugular vein, the vagus nerve, and deep cervical lymph nodes. Now let's talk about the blood supply of the thyroid gland. The arterial supply includes superior thyroid artery and the inferior thyroid artery. Superior thyroid artery is the first anterior branch of the external carotid artery, which has an intimate relation to the external laryngeal nerve. At the upper pole of the gland, the artery divides into anterior and posterior branches, as you can see in the figure. The inferior thyroid artery is a branch of the thyrocervical trunk, which in turn arises from the subclavian artery. The venous drainage includes superior thyroid vein, inferior thyroid vein, middle thyroid vein. The superior thyroid vein ends in the internal jugular vein. The middle thyroid vein also enters the internal jugular vein. The inferior thyroid vein forms a plexus in front of the trachea and drains into the left brachiocephalic vein. Sometimes a fourth vein of Kocher may be emerged between the middle and inferior veins and it drains into the internal jugular vein. The superior thyroid vein, the middle thyroid vein and the inferior thyroid vein, and this is the Kocher vein. Now let's talk about the surgically important relations of the thyroid. First is the capsule. There are two capsules, the true capsule and the false capsule. The true capsule is the condensation of the connective tissue of the gland. The false capsule is derived from the pretracheal layer of the deep cervical fascia. A dense venous plexus lies deep to the true capsule in the thyroid gland, unlike the prostate gland. Therefore, to avoid hemorrhage during thyroidectomy, the thyroid gland is removed along with the true capsule. So the plane of cleavage lies between the false capsule and the true capsule. Next is the relation of the superior thyroid artery and the external laryngeal nerve. The superior thyroid artery and the external laryngeal nerve are closely related to each other at its origin. Near of the upper pole of the thyroid gland, the superior thyroid artery and the external laryngeal nerve are separated from each other. Therefore, during thyroidectomy, the superior thyroid artery is ligated near the gland to avoid injury to the external laryngeal nerve. Next is the relation of the inferior thyroid artery and the recurrent laryngeal nerve. The inferior thyroid artery and the recurrent laryngeal nerve are closely related to each other at the lower pole of the thyroid gland. Therefore, during thyroidectomy, the inferior thyroid artery is ligated away from the gland in order to avoid injury to the recurrent laryngeal nerve. Next is save the parathyroids. The parathyroids are present in the posterior aspect of the thyroid gland. In subtotal thyroidectomy, the posterior parts of the both lobes are left behind. This avoids the risk of the simultaneous removal of the parathyroids and also of the post-operative myxedema caused by the deficiency of the thyroid hormones. and also the post-thyroidectomy hypoparathyroidism. The treatment includes radioactive iodine and the surgical treatment. What are the indications of the thyroidectomy?
Your doctor may recommend a thyroidectomy if you have certain thyroid cancers, an enlargement of the gland called a goiter, benign nodules, cysts, or an overactive thyroid.
The surgical treatment involves total thyroidectomy, semithyroidectomy, subtotal thyroidectomy, and lobectomy. In total thyroidectomy, the entire thyroid gland is removed. In semithyroidectomy, the entire gland is removed, leaving the small posterior part to avoid injury to the parathyroids. In lobectomy, specific lobe of the thyroid gland is removed. Either the left lobe or the right lobe or the pyramidal lobe is removed. Here you can see the picture of the total thyroidectomy for Graves' disease. Lastly, I would like to say that don't worry, everything has solutions. And don't forget to have iodized salt in your diet because iodine is required for normal functioning of the thyroid gland. Remember, for hypertensives, salt restrictions are present. Therefore, iodine deficiency can be present, which can lead to alterations of the thyroid gland functioning. Therefore, they have a substitute. Can you imagine what is it? Yeah, the bread. Iodine. It contains iodine, which can suffice the iodine requirement of the body. Thank you.